Good afternoon, everyone. It is such an honor for Michelle and I to be before such an esteemed audience to present the future of integrated care, the partnership between the Rock Creek Foundation and Sante Group for our holistic approach to support. My name is Najla Wortham. I am the president of the Rock Creek Foundation. I am a 40-year-old melanated woman with curly black hair, wearing a teal dress and a cream and gold blazer with leopard print shoes. I mean, it probably looks better than it sounds. I have spent over 20 years of my career working with individuals with intellectual and developmental disabilities, as well as severe and persistent mental health diagnosis and substance use disorders. I have advocated for a number of years for systemic equity and accessibility and allowing individuals with multiple disabilities to live lives that are meaningful for them and in communities that they choose.
Good morning. My name is Michelle Grigsby Hackett. I am a fair-skinned African-American individual. I stand 5 feet tall with some wedge shoes, probably about 5'2". I am slim build, and I am wearing a white dress with blue and green flowers. My hair is straight and about mid-shoulder length, and it's back in a ponytail, and the color is red and brown. Probably my description looks better than it sounds as well, but we felt that it's very important. We are among individuals with varying abilities, and so being able to live through sight, sound, hearing, being able to absorb information in a multitude of ways, we wanted to describe ourselves. Thank you. I am the CEO of Affiliated Sante Group, lovingly known as Sante. I have been in the behavioral health space for over 25 years. I am a clinician by trade, but in the last 15 years of my role, I have been responsible for advocacy, program development, and operational supports for individuals that or serving individuals that have co-occurring needs, mental health conditions, substance use conditions, individuals with in the IDD community, across the spectrum of serving clinical needs, rehabilitation needs, and crisis needs. The work that Najla and I do in the States is really important in terms of advocacy, making sure that the voices of those are heard, are understood, and that they're able to live fulfilling lives of their choosing. We are excited today to talk to you about the work that we collectively do.
So this presentation, we will explore co-occurring disorders through the neurodiversity lens. Neurological differences such as autism, ADHD, dyslexia, and other cognitive variations are natural variations of the human brain. The term challenges traditional deficit-based models and promotes inclusivity. Neurodivergent individuals have unique strengths and perspectives that contribute to innovation, creativity, and problem solving. In the past, individuals with intellectual and developmental disabilities were often presumed incapable of experiencing or articulating mental health issues due to their cognitive impairments. This misconception led to underdiagnosis of psychiatric conditions, lack of appropriate mental health treatments, and increased vulnerability to abuse and neglect. Underdiagnosis is still very real. Studies show that individuals with IDD are up to 4 times more likely to have a co-occurring mental health condition, yet these conditions are underdiagnosed because symptoms are often misattributed to the disability itself.
In terms of the prevalence of mental health conditions within the IDD community, individuals with intellectual and developmental disabilities are at a significantly high risk of experiencing mental health conditions compared to the general population. Studies have shown that 21 to 34% of adults with IDD have co-occurring mental health conditions. Some of the common co-occurring mental health conditions include depression, anxiety disorders, bipolar, and psychotic disorders.
So a brief overview of the Rock Creek Foundation, which again is a United States-based nonprofit organization headquartered in the state of Maryland and also spans throughout the state of Pennsylvania. For over 50 years, we have operated at the critical intersection of mental health and disability services. We've been a pioneer in delivering integrated community-based services for these individuals. Our model is built on a person-centered philosophy that honors the dignity of the individual, supports growth through meaningful risk-taking, and sustains progress with ongoing skills development. We believe in the value and potential of every person, and we are committed to creating pathways for independence, inclusion, and lifelong success. Our mission, the mission of the Rock Creek Foundation, is to support and champion opportunities that enables individuals to shape their own destinies. We envision a diverse world where all individuals of all abilities are empowered to unlock their full potential. We believe that disability or mental illness should never limit someone's ability to live fully. That's why we have been helping individuals build the skills to live independently, thrive in their communities, and reach their full potential. Oops, sorry guys, I was on the wrong slide. Well, I will talk about the CCRN then. Rock Creek Foundation, as I mentioned earlier, we have expanded our reach into Pennsylvania. We own and operate a subsidiary company known as Chester County Respite Network that is located outside of Philadelphia. We provide an array of intellectual and developmental disability services, behavioral health services, and school and community-based services to youth. Our model is based on board-certified behavioral analysts that work alongside the students and their families, as well as their school staff, assisting them with completing functional behavioral assessments, drafting and developing their behavioral plans, as well as being a part of their IEP teams. And our behavioral consultants work directly with training our one-on-one staff that work with our students to be able to be integrated into whatever community of choice that they choose, whether it's inside the school, whether it's in after-school activities, or whether it is within their homes with their caregivers. This organization allows us to, again, expand our footprint, and CCRN is about a $3.5 million organization. Rock Creek's mission and vision, and what we do. So at Rock Creek, we, through a combination of therapeutic rehabilitation services, we allow individuals with severe and profound mental illness remain or integrate back into their communities of choice. Our services are steeped in the fundamental belief that every individual has the right to live in the community of their choice, utilizing non-professional or professional supports. We provide an array of community-based support services, from residential rehabilitation, supported employment, psychiatric rehabilitation, personal supports, affordable housing programs. I mean, it's a full gamut, which I will visually show you guys on a slide to come. Our program is built upon the individual strengths of each person, recognizing that personal achievement is fostered through positive reinforcement. Our approach is a holistic approach to improving the health and well-being of people living with multiple disabilities, as well as individuals with singular diagnosis. It's based on the belief that growth and change are possible for each person. Our programs are designed to ensure that individuals can be integrated into existing community services whenever possible. We utilize a variety of skill and training resources, including health, recreational, social, and vocational, to enhance independent functioning and stimulate progress through levels of competence. This is a visual of our disability programs at Rock Creek Foundation, and as you can see, we have a variety of support services that we provide in the community to the individuals that we support. From nursing support services, which encompasses routine nursing assessments as well as medication assessments, coordination of doctor's appointments or discharge planning from hospitals, as well as 24 hours of nursing triage support for our residential homes and the residents that we support. We provide respite care services, environmental modifications to allow individuals to age in place in our settings, as well as assistive technology devices for communication enhancements, etc. We provide transportation supports, which could include travel training, which could include advocating for funding for individuals to be able to utilize Uber or Lyft, is what it's called in the United States, to get to and from work or to access their community. We provide an array of community living, group home supports, and that can be from 24-hour group home, traditional group home model where we have staff around the clock. We operate about 25 homes in the state of Maryland in 3 separate counties. We provide supported living where we provide staff support within an individual's home or within their caregiver's home. Day habilitation, where we provide therapeutic groups throughout the day for individuals that may not be ready to work at that point or self-identify as being retired. And we provide an array of skill-building groups during the day as well as recreational activities. We provide supports to individuals that have intense medical or behavioral needs, so increased acuity needs, and sometimes that dictates our staffing patterns for those individuals. So some individuals we have one-on-one staff supports or even two-on-one staff supports depending on the needs of the individuals we support. We provide family and peer mentoring, family caregiving training and peer support, and an array of employment services. We provide employment supports for individuals to explore, so discovery, what am I interested in? What type of careers would I want to enter? Do I want to attend college? We customize employment for individuals based on their preferences and interests. We provide skill-based groups, so helping individuals develop resumes, helping individuals learn to dress for success, helping individuals learn how to travel to and from their places of employment. Once an individual is employed, we provide staff that go with the individual to their employer, train them on the job, help them build relationships with their colleagues or coworkers as well as their supervisors, and really just provide ongoing support. Sometimes we see individuals can be employed for a number of years and they may get a new supervisor that has new rules, and so we'll have to go back in, or new expectations, and train them on their job to make sure they can remain successful. Ooh. I'm not good with a clicker. This is a visual view of just our funding structure. In the state of Maryland, our disability services are funded through the Developmental Disabilities Administration, and our mental health services are funded through the Behavioral Health Administration. Rock Creek is one of very few organizations in the state of Maryland that is duly licensed, and so we provide services to both individuals with intellectual and developmental disabilities as well as severe and persistent mental health diagnosis. And so we really have two sides of our organizations, and we parallel services across both funding streams. The Developmental Disabilities Administration in Maryland runs 3 special Medicaid waiver programs, home and community-based services. The programs include the Family Supports Waiver, Community Supports Waiver, and the Community Pathways Waiver. A Medicaid waiver program is approved by the Federal Centers for Medicare and Medicaid Services, or CMS, and allows states to make exceptions to usual rules. This enables Medicaid and other services to be provided in different settings, tailored to individuals with different needs or varying income levels. For those who qualify for these programs offer services within the community as an alternate to them being in an institution. As you can see, Rock Creek is about an $11 million organization, and 70% of our revenue is attributed to our IDD programs. In combination with CCRN, we're about almost a $15 million enterprise. So our approach, our holistic approach to integrating these disability and mental health services, this model integrates clinical expertise, community-based supports, and cross-trained staff to deliver holistic, individualized care. At Rock Creek, we bridge the gap between IDD services and mental health care, and we deliver comprehensive person-centered support for individuals with dual diagnosis. The 3 components of our model is the person-centered planning, which is individualized service plans are tailored to support both IDD and behavioral health needs of the individual in one coordinated plan. Workforce development, in which we cross-train our direct support professionals to equip them to navigate complex needs, clinical oversight, and ongoing coaching. And then data and outcomes. Our behavioral health electronic medical record integrates with our IDD service data, real-time tracking of crisis episodes, medication changes, critical incidents, etc.
And a bit about Sante. Just a second. So, Sante is the sister company of the Rock Creek Foundation. Leveraging the expertise that the Rock Creek Foundation built in 1972, Sante grew in 1991 to serve a broader population that was considered underserved. Our organization prides ourselves on looking at the needs of the communities, looking at where the gaps and barriers are, and being the ones to be able to fill those gaps. So in 91, we were established, or 92, we started services, and our behavioral health services are one of the largest and oldest within the state of Maryland. The other division of services we provide, which is crisis response, is the largest in Maryland, as well as serving in North Carolina. Our work has been focused on working with individuals with co-occurring conditions, individuals with substance use conditions, as well as mental health conditions, and the IDD population. At Sante, we lead with advocacy, education to challenge and respond to the stigma and foster a more accepting and open environment for people to authentically be themselves. Our team members provide a judgment-free space where you will always be able to be seen, heard, and supported as we work together toward your wellness goals. We believe everyone deserves to find their way towards wellness. With us, you'll have a team that walks right beside you and keeps you growing. Whether you're an individual looking to feel less alone or an organization needing support to change the mental health and crisis landscape, together we can achieve complete and total wellness for every individual, however they choose to define. So about our mission, vision, and values. It's important that we live by our mission, which is to inspire hope in our communities by providing quality services, advocacy, and education to promote emotional well-being. This is something that we do in our everyday work. Our vision is to envision a society where everyone has access to experienced, compassionate support to navigate their path to wellness and independence. Our values, we are woven throughout our organization, and they are focused on recovery and resilience, accountability and integrity, diversity, equity, inclusion, accessibility, innovation, and initiative, as well as safety. So our funding structure, we are licensed by Maryland's Behavioral Health Administration, and that license allows us to provide community-based behavioral health services. Again, we're the largest in the state for crisis, and we're one of only 2 standalone crisis providers in North Carolina. The rest of the state provides crisis services as an add-on to other services. The importance of our being a standalone crisis provider is that anyone can come to us whenever they need support and assistance during a crisis event. We receive funding through federal, state, and county and local grants, as well as reimbursements through Medicaid, Medicare, and private insurance. Many of our services are covered by individuals' medical coverage, which allows us to bill the insurance companies for their service. Our grants represent 82% of our business, and collectively, we are a $22 million organization providing outpatient clinic services, which includes therapy and medication management. Our psychiatric recovery services. Those are provided in a facility as well as in the community, in which we teach life skills to individuals with chronic mental health conditions. As some of the life skills that are taught are independent living skills, education skills, medication education, understanding your mental illness, how to help cope with symptoms, all skills that help individuals to live independent and full lives in the community. We have peer-run wellness and recovery centers. Those are led and run completely by individuals with lived experience. And so that's more of a support environment where individuals who have a lived experience with, whether it be a mental health condition or a substance use condition, they have an open and welcoming environment where they can come and network with other peers. They can share their stories. They can provide resources to one another, as well as build a community to help with advocacy and living within their community. Our crisis response services include our local hotline, crisis hotlines, as well as national. In the United States, about 2 years ago, the country went to an easy number to remember, 988, as the crisis and suicide prevention lifeline number. Sante represents one of the 6 providers in Maryland that provide the crisis 988 hotline services as a certified vendor. We also provide mobile crisis treatment. So mobile crisis services involve a clinician and a peer or a clinician and officer partnership that responds in the community to anyone or community member, individual, or an organization who may be experiencing a crisis. And a crisis is defined by the person. So it could be distress from family conflict. It could be a recent car accident. It could be a job loss. Anything that causes distress to the individual who needs additional support to navigate that challenge, we will respond to. Those responses happen in person or through telehealth, in which someone is able to talk one-to-one with the clinician or with the peer to help walk through what the crisis event is, how to navigate de-escalation from that crisis, intervention from the situation, as well as planning for how to address longer-term challenges that may arise. We also provide training through our crisis services. We train law enforcement and other first responders. We also train community members to help recognize if an individual is experiencing distress from any symptoms or any situation that they are experiencing, how to help them in the community so that the reach is broader, so that people can be of support to individuals that need assistance. And we provide managed services. So that's our back office. When we are providing care to individuals, there's a lot that happens behind the scenes that, folks don't see, like being able to bill the services, the billing department, the finance department, human resources, our compliance department. We provide those services to the organizations that are within our network, as well as being contracted to provide those to other organizations so that they can really focus on the work of providing care. Our integrated care model is built on the philosophy that we take a person-centered approach. We uncover strengths and needs of the individuals and make sure that they receive the best and quality care possible. We make sure that our care is individualized. It's not a one-size-fits-all model. We make sure we understand what is the individual's needs, what are their resources, what are the gaps, and then we are able to tailor a plan that is person-centered to that individual. We foster a multidisciplinary team. One of the most important things is that individuals cannot receive care in a siloed system. That holistic, integrated care involves a multidisciplinary care team. So that includes the counselor, that includes a case manager, that includes the psychiatrist, that includes the residential provider. It includes all of those that touch the individual so that we are working with them in a manner that addresses all of the needs that they have. And our services are flexible. Again, we provide services in the community. We have facilities that individuals can come to receive services, and we're able to provide care through telehealth. Accessibility has been challenging, especially in our rural areas. So where we found that telehealth is really helpful in areas where transportation may be difficult, or where resources are limited, we can extend our reach. Walking through the services that we provide. For therapy in our clinic, we do individual, family, and group. We have medication evaluations with our psychiatrists and nurse practitioners, as well as ongoing management for prescribed medications. We provide cognitive and dialectical behavioral therapy. Supportive groups for parents of children. We see a lot of children in the school system. And so again, as an integrated care and interdisciplinary team, we have to pull in the family members. They're part of that student's care team. And so making sure that they have the support that they need in being able to address the needs of their child. Psychoeducational groups, school-based therapy, crisis management, community peer support, and telehealth. Training is a significant component to the work that we provide. We make sure that our staff are trained in models of care that will cover those that we see. We make sure that we have education and training platforms, making sure that a strength-based approach and motivational interviewing are models that are utilized in the care that we provide. Specialized training on IDD, mental health, and substance use to make sure that our staff are aware and well equipped with supporting. Oops. And the last one, we also just wanted to go through our impact by the numbers. So in fiscal year 2024, which was July to June, for crisis, we were able to assist 50,000 calls. We maintained a 90% satisfaction rate. We saw 6,637 individuals in crisis, Our stabilization rate is 92%, which is relatively high. And when we talk about stabilization rate, that is determined by being able to support individuals without having them go to a hospital. We were able to support them in the community, whether it's their home or wherever the least restrictive environment is, and reduced the chances of them returning for the same crisis event. We diverted 1,100 from hospitalization and diverted 234 individuals from incarceration. Our crisis services are a diversion model. The goal is to make sure that care is provided without the utilization of higher levels of care that are often not as successful, which is hospitalization and jail. Obviously, we cannot divert everyone, and it can be appropriate for individuals to go to a hospital, but our work really is to support them in the community. The savings to the state in terms of hospitals and jails has been $4 million last year. This is a significant investment as our state has one of the highest hospitalization waiting room waits in the country. So the more that we could provide those community-based services and not continue to have individuals use hospitals as a means of service where that they can get in the community has been very significant for reducing those, helping to reduce the backlog in hospitals. And then for our outpatient clinics and other services, 50,000 served, 2,100 in our psychiatric recovery programs, and then a total of services, individual services, was 15,000. So now we'll talk a little bit more about the model of integration that we use together.
Well, I didn't include my impact, Michelle.
I'm so sorry.
But at any rate, based on everything that we just explained to you guys that we do, we noticed that there was a fragmented system within the state of Maryland. And historically, Maryland's Developmental Disability Administration, as well as the Behavioral Health Administration, as Michelle mentioned, have operated in silos, which led to disjointed care for individuals with co-occurring and IDD mental health conditions. This separation often resulted in challenges across the state, such as delayed or inadequate mental health interventions, difficulty in navigating between services, lack of comprehensive integrated treatment plans, different or inadequate training, staff training requirements, fragmented crisis response and emergency preparedness efforts, higher caregiver burnout, and family struggles and psychotic disorders.
What we also learned through our experience in working with respective individuals is, it is moving on its own. There you go. Okay. Is the importance of equitable access to treatment and services. Many neurodivergent individuals, especially those with intellectual and developmental disabilities and co-occurring mental health conditions, face the fragmented care. Integrated holistic approaches improve stability, independence, and quality of life. The importance of inclusion and independence. True inclusion goes beyond basic accommodations. It requires shifting societal perspectives, mindsets to prioritize autonomy, self-advocacy, meaningful community participation. These are critical aspects of embracing neurodiversity.
So based on our relationship and the services that we provide to the state of Maryland and oftentimes to shared individuals that we support, we decided to come together as organizations and develop an integrated care model, which has several different steps or components of the integrated model. So Rock Creek partnered with Santé's outpatient mental health clinic to build a truly integrated care approach where clinical expertise is embedded in everyday life to meet the complex needs with compassion, consistency, and skill. Through this collaboration, individuals at the Rock Creek Foundation receive specialized psychiatric treatment tailored to their dual diagnosis needs, immediate crisis intervention to stabilize and prevent hospitalization, access to interdisciplinary care teams that aligns clinicians, our direct support professionals, case managers, and families, coordination of care activities such as team meetings and information sharing, such as medical records and treatment plans, and platforms to ensure care is safe, effective, and meets the needs of our clients. This model ensures that mental health care is not an add-on, but a core part of how we support our individuals every day. So the first component of Rock Creek and Santé's integrated care model is appointment and treatment integration. We were able to develop seamless scheduling across all of our settings. So our staff schedule and track mental health appointments, ensuring continuity of care across all of our programs. My residential staff has direct access to Santé's clinical team, whether that be the individual clinician or their psychiatrist. If we have an individual that is presenting not at their baseline, we're able to call the clinic directly, speak with their treatment plan team, and kind of triage with our residential staff on how best to respond. We have unified treatment plan goals, which is very dynamic in the state of Maryland, to have a treatment plan that is comprehensive and includes the treatment goals for an individual that has disability goals as well as mental health needs. So we align with therapists and psychiatrists to reinforce treatment plans consistently, helping individuals make progress in every environment they engage in. So our employment team meets with the clinics, our residential team meets with the clinics, the families and caregivers meet with the clinics to ensure that everyone is trained on that individual's individualized treatment plan goals. There's flexibility in services. Again, we have open access to the Santé team whenever we need to have access to them, and Santé has been able to tailor service delivery to include in-home telehealth services to meet the specific needs of the individual served.
The second component is leveraging our expertise with crisis response. Santé's crisis response is available to Rock Creek Foundation 24/7, so that if situations arise and a local crisis team is needed, we're able to deploy our teams and respond to help those that may be experiencing self-harm or aggressive behaviors. We're also able to coordinate emergency petitions. In the United States, if an individual is experiencing heightened symptoms and behaviors that could be detrimental to themselves or others but are unwilling to go to a hospital, the clinical team can request or complete documentation to obtain a hospital evaluation for the individual. So being able to leverage our relationship, the clinic staff are able to write the emergency petition so that the residential care teams can take the individual to the hospital and be seen more expeditiously. We also are able to provide immediate clinical appointments. The good thing is that the team on hand, due to the relationship, we're able to expedite and bring in individuals or have a telehealth appointment for consumers if they are experiencing escalated symptoms, either same day or next day. And then crisis debriefings. We make ourselves available to be able to conduct debriefings with the residential staff or Rock Creek staff, whatever department they may be in, so that if they experience a crisis event, and even if the residents of a group home experience a crisis event for their peer, that we're able to come in, do debriefing sessions, help them process what happened, and help them be able to navigate any challenges that arise.
Within the state of Maryland, our services are funded and provided through two separate administrations, one of which being the Developmental Disabilities Administration, as well as the Behavioral Health Administration. And what you'll see is that there are differing staffing requirements. Michelle, go back.
Oh,
the clicker, I think it's just clicking on its own.
Yes.
There are different staff training requirements. So if you are funded in providing services under or through the Developmental Disability Administration, the staffing requirements are very much centered upon assisting individuals with training them on their ADL, social and recreational activities, maybe employment, behavioral modification, things of that nature. And if you are providing services under the Behavioral Health Administration, then the staff training requirements are very focused on mental health, crisis management, medication management, coping skill development, things of that nature. And what we found was that we needed to develop an approach that combined those training models to ensure that we were equipping our staff to manage the complex needs of the individuals we support. And so what we decided to do was develop our own integrated training plan or model that goes directly from the top down. So it starts with the C-suite all the way down to the staff that provide our direct supports.
And the importance of that is that we have to build a culture organizationally that the individuals that are being served are going to make sure that they are being cared for in a way that is one, quality-based, two, based on training and expertise, using evidence-based models. So we went above and beyond what the minimum standards were for the state to make sure that we are training and equipping our staff with all of the skills and education that they need to be able to provide the best services to individuals.
And some of the training that we provide across both of our organizations is mental health first aid, trauma-informed care, strength-based and resiliency models of care, education and co-occurring conditions, cultural and linguistic competence, person-centered thinking, suicide risk and screening,
sexual abuse and awareness, crisis prevention and intervention, critical incident stress management, abuse and neglect, MANT, LGBTQIA+, safety planning, and Narcan administration.
Our hiring practices ensure that clinicians, psychiatric providers have intensive background and experience to ensure a standard of quality for individuals with complex needs. So alongside another component of our integrated care model is joint advocacy efforts. Because we have such a unique vantage point in our relationship and the services that we provide, as well as the funding systems that we utilize, sometimes we have to enlist each other's expertise to advocate for funding across our state, whether that is in our local jurisdictions, at the state level, or even federally. And so we collaborate a lot to submit letters and documentation to funding sources, whether that be Medicaid, private insurance, and local jurisdictions when critical services or staffing needs are denied. A lot of times what we're seeing and becoming more prevalent even recently is that there's a lot of cost containment measures that's happening across the United States in which individuals are being denied for crucial services that they need. And so in order to advocate for increased services as an individual's needs change or their acuity needs increase, sometimes I have to lean a lot on Michelle's psychiatric staff and clinical staff to be able to write the letter of support to support the additional staffing and support that may be needed.
Additionally, we provide, it just doesn't go beyond advocacy for funding. We advocate about policy changes, regulation changes. Even in the last year, we've had to go down to our legislators' offices. We had to speak to our general assemblies to make sure that policy changes that they were looking to implement were not going to be at the cost of the individuals that we serve. One of the things that also has been important is that we've brought individuals served to those advocacy appointments. One, it's important to teach individuals to advocate for themselves, to give them opportunities to advocate for themselves. Because again, their voices are the ones that need to be heard. Our voices are the ones that need to be heard. And so we do that collectively, setting appointments collectively, having individuals that we serve attend the policy meetings and hearings to be able to speak at those hearings so that the legislators hear what the experience is from the individuals receiving the services and what the challenges are, as well as if policies are changed, what impact that would have on those individuals directly. We have an outcome-focused partnership. Our integrated approach ensures that individuals receive consistent, person-centered care that promotes long-term stability, independence, and quality of life.
So what are some key takeaways for the success of our integration of our care model? Individuals with both developmental and mental health needs deserve care that is coordinated, person-centered, and holistic. Siloed services miss the full picture. Integrated care leads to better outcomes, greater stability, and true inclusion. We've seen a reduction in the consequences of neglect. The failure to recognize and address mental health needs often results in an exacerbation of behavioral issues, higher rates of institutionalization and criminal justice involvement, and an overall diminished quality of life for the affected individuals.
And then what's needed is the shift from fixing to empowering. Neurodivergent individuals were once seen as needing correction through medical or behavioral interventions. Strength-based approaches prioritize abilities over deficiencies or deficits. This shift opens doors to inclusive education, employment, healthcare, and community life.
So some brief impacts that we've seen from our integrated care model, some successes is that when neurodivergence is acknowledged and supported through a strength-based, person-centered approach, treatment outcomes improve significantly. And this includes lower hospitalization and crisis intervention rates, increased employment success, and overall better well-being.
And by embracing cognitive differences in mental health and IDD treatment, we shift the focus from limiting individuals to empowering them with the right support, resources, and opportunities for success.
Thank you.
Thank you very much.
That's our presentation.